Today, Mike and I are here talking with pain management specialist, Dr. Kavita Gupta, and we're going to talk about all things peripheral neuropathy, the management of that, and the type of patients that come in to see pain management specifically. So thank you for being here today. I'm really excited, both of you.
Thank you. Thank you.
So let's start out by talking about what kind of patient seeks pain management, and with neuropathy specifically, what are some of the different causes that can cause a lot of confusion, whether it's neurology, what type of specialist that they'll see initially for diagnosis?
Right, so being a pain management and rehab specialist, so pain management is sometimes a specialty that a lot of people aren't familiar with. And oftentimes it feels like a doomsday when they've been referred to pain management, or they might think it's a, aha moment because someone's going to help me. And when that happens, it's usually sometimes, coming from a specialty, or in this case, most of which I'll see is primary care referrals, primary care, or even some subspecialty. And it's oftentimes not clear either at that point. They've kind of done what they could, like an orthopedist might refer something. You've had surgery, you've had everything, we've corrected everything, there's nothing anatomically wrong, you still have pain, see pain management. Primary care, you have a bunch of different diagnoses, you're asked by the assistant, what's the chief complaint? What's the reason why you're here today? Well, yes, you suffer with chronic pain, but that might not be the number one. You might have an upper respiratory infection. They checked your heart and lungs, they've given you antibiotics, and that's taken about 10 minutes of their time, 10, 15 minutes, and that is the visit.
Right.
And you really don't have that much time, but doctor, I have this. And that oftentimes is that chronic problem that just is underlying, is the background noise that doesn't get addressed thoroughly, and you just live with it because you don't have the time, because it's not the number one thing, and oftentimes when it's ongoing and repeatedly there, and it's a steady state, it's when the primary or the specialist is going to refer, and they're like, go see pain management. Now, I'm assuming when that referral comes over, I have somewhere to pick the race up from. Like, I have some data.
Yeah.
Some data has been done, some things have been ruled out, or things might not have been done. And it kind of falls on me to start assessing, looking thoroughly, asking the questions that might not have been asked. And a lot of the time, I know in my own training and in any medical school training, medical students are always taught, you can primarily figure out the diagnosis. You can kind of figure out majority of what you're dealing with by asking the right questions.
So when somebody comes in, do they typically have all of the testing that they need, or not always?
Might have, but not always.
Okay.
Or a lot of things might be missing, or the basics might not be there.
Like what? Like an EMG?
EMG
skin
is
biopsy?
Skin biopsy is never done.
Yeah.
EMG may be done, but it might have been done for a different reason.
Right.
It might be looking for something else and not a thorough EMG. Oftentimes, the most reliable source, if it's coming from a pain management case, it might be co-treating with a neurology specialist who has maybe the specialty knowledge, like in their arena. In each specialty, there are subspecialties, right? So a neurologist who might be focusing on stroke management and doesn't see enough peripheral neuropathy may not be the one who is going to adequately give you all the data you need, because you can't think, I saw a neurologist, well, they might be a migraine specialist, they might be a stroke specialist, they might be a motor disorder, movement disorder. Movement disorder specialist who they have within their own realms of identification of what they're handling. So when it comes to me, I'm kind of like tertiary and trying to put all the points together and see where I can have, because the pain is controlling their life and they've become dysfunctional and they're requiring some sort of cohesiveness and understanding what to be on, what medicines they need to be on, or what they need to do, or what's not been worked up. So I kind of have to, each case is different.
Yeah.
Very different.
Mike and I tend to see a lot of people that usually have an EMG because they're seeing neurology first. Pain management has been on the outskirts of the referral process of, whether it's mechanical,
Right.
metabolic, drug-induced, what is your opinion on how much we're missing, excluding chemo, how much we're missing drug-induced neuropathies and things like that as well, like antibiotics, fluoroquinolones are known to cause them and things like that. So you see a multitude of causes, I'm sure.
Oh, absolutely. I mean, peripheral neuropathy is a big basket of diagnoses or things that can be leading up to peripheral neuropathy, just like you said, drug-induced, even like HIV, peripheral diabetic, any like vitamin deficiencies, any of the CIDP, any of these things can give you those neuropathic type symptoms. Now, how you kind of divert and trying to figuring it out is the question. Like, for instance, a lot of number one reason of what I see in pain management is low back pain patients. Low back pain patients who've had maybe a severe herniation or a back surgery that caused them radiculopathy, all right, or sciatica. So what are they experiencing? What are the symptoms these patients are experiencing? Burning and tingling and numbness in their hands and feet, or depending where the radiculopathy is coming from. So those symptoms can mimic a lot of what you see in peripheral neuropathy, the burning, the tingling, and maybe some weakness. So then it comes to me to kind of filter through it and see what kind of loss, what other metabolic issues they may have going on. If they have uncontrolled diabetes, do they have any history of autoimmune disorder? Do they have any deficiencies in their history? I have to kind of probe and like pick and look and see what could it be if there's something. It's, you're really kind of figuring out, because the symptoms are all the same in every one of these cases.
So can you also just touch on what radiculopathy is, just briefly?
So radiculopathy, let's say we're talking about the low back. So low back next to upper respiratory infection can be the first, second cause of why they'll see their doctor, right? If you have a herniated disc and it's hitting a nerve, you can start getting numbness, pins and needles, paresthesias going into your legs. And the differentiating thing with peripheral neuropathy and radiculopathy is that it can affect both legs, or it can affect one leg, and it can follow a dermatome. It can follow, and they'll tell you clearly that, it goes down the leg on the outside and the bottom of my foot, and and I'll be very specific and says, show me exactly, draw me a map on your body where you're feeling that pain, and they will tell you exactly. If it's truly coming from the back or radiculopathy, they'll tell you that. Peripheral neuropathy, or any type of idiopathic peripheral neuropathy, any type of neuropathic pain, is that classic textbook. They may have stocking glove distribution, where they get pins and needles only specifically in their hand, or maybe in their feet, and it'll be kind of rising upward. It'll kind of go from the hands up, or from the feet up, and it's not typically going down. And then we're seeing it constant, it's symmetrical, it's in both limbs and all the limbs. So that's one clue that we can have it. But the question becomes with the patient who has both. What if you have both? And then you're going to have similar symptoms.
You have a lot to rule out.
Yes, you have a lot to rule out, and there's a lot of layering that's going on with their pain. So nobody is made with only one problem. Everyone has a multitude of things, and it's a layered thing. It's like peeling away at it, trying to get to the core of which one is the problem that's amplified the most and giving you the symptoms at hand. So is it the neuropathic pain, or is it the radiculopathy, or is it a deficiency? Like,
can it be both?
Very much. It can be very much both.
So do you think that because of the complicated clinical picture that these patients present a lot of the times, this is why diagnosis gets delayed? I want to say the average is 7 years for most people.
Easy, because a lot of times there's once you get designated to see a specialist, there's a workup involved. There's like an intense workup, and it might not just involve one specialist. It might involve more than one. I might need another specialist's opinion to give me an idea of what's going on. Because I'll give you an example. I'll give you a little quick story that I kind of like to use this as an analogy for medicine and doctors, right? So there was like a teacher or something in some rural part of India, And he had his students go out. They were all blind students. Took them all out, and he says, and it was an elephant, okay? These students did not know it was an elephant. And each person was asked to go to different parts and feel this elephant. One person felt the leg, said this is a tree trunk.
Edematous.
Yes, and one person felt the body, they said it's a boulder. So, and then what I'm trying to say is that each person's interpretation can be very different, right? So, but when you put them all together and you put all the data points together, it can give you a better, clearer picture. So that's exactly what medicine, it's not, you can't just rely on one person. Your primary care, granted, they do a lot of work for us, but they need help. They do need help. They need the specialist. And if you, as a patient, feel that you're not, you think there's more, and your intuition will tell you, ask for the specialist. Yes. Get that opinion. Request for the opinion, because they are also limited. They cannot get, everything, all the information to you. They need the resources to kind of compile a treatment plan.
Do you have any questions?
A couple. So one of the things I was thinking about when we were talking about forms of neuropathic pain, like the different categories of patients. Obviously, diabetic polyneuropathy, idiopathic is the vast majority. It's really hard to pinpoint if there's an autoimmune or immune-mediated origin. What are your thoughts on the immune-mediated category?
Immune-mediated, rheumatology is the guru in that area, right? So then oftentimes, if you're going to get, and I'm dealing with a case right now, a patient who is having this chronic kind of pain that's kind of giving her these symptoms that sound very mildly CIDP-ish, but she's being ruled out. Her markers are coming back negative, but it's potentially, she has a strong family history for autoimmune disorder. Yeah. Now, markers, you can't treat labs. Like even, you see labs, yes, you have your guided information there, but sometimes, you're just not, you can have this idiopathic situation where idiopathic meaning you just don't know why, and you could be just dealing with this scenario that you have this condition, we can't tell you why, nothing is pointing us in that direction. So autoimmune, we start with the markers first, looking at all the RA, the ANA, the different, for Sjogren's, and looking for all the different things that could potentially give us a clue that we might be dealing with the autoimmune disorder. Awesome. So I rely on my rheumatology colleagues to give me that input. If there's other issues from a neuropathic standpoint, like if they're diabetic, like obviously I have endocrinology involved. I'm looking at hemoglobin A1C. Do we have any other metabolic deficiencies? Are we looking at B12? Are we looking at B6? Some of these things can be easily corrected, like the vitamin deficiencies. Now, if your vitamins are off, easiest way to do is resupplement and correct them. Too much of one or too less of one can still give you a problem.
That needs to run out. Yeah.
Yes.
Or chelation, I think.
Yes.
You can do.
So, and then if you have a history of cancer, you can have radiation, neuropathic pain. So the key is, like I said first, was the history. Yeah. So, and a lot of times patients don't give you all that information. Oh, I forgot to tell you, I had this. Yeah. And you'll be like, wow, that's a game changer moment where if I didn't know that, that could have maybe made my thought process different.
It's like when I ask a patient, are you on any, do you have any medical issues? And they say, no. Yes. But then I ask them their meds, and it's
exactly.
25 meds.
Yes, that's
like some high blood pressure, high cholesterol.
No, the medicines give it away. Right. You can diagnose them based on the medications they're on.
No.
It's thyroid disease.
Constant.
But oftentimes they'll think that if they're on the medication and their blood pressure is good, I don't have high blood pressure anymore.
Right. Just today, somebody said that to me. Oh, I don't have high blood pressure. But you're taking blood pressure. Well, that's why I don't have it anymore.
Yeah, exactly, because it's controlled, So it's a very common sort of thing. So I spend time educating the patient, trying to make them understand the importance. Pain management is just like we don't have a cure for diabetes, right? We can only manage it. We can only manage.
I'm diabetic.
Right. So we don't have a cure, but maybe we're getting close. Who knows?
I think we are.
We are getting close. We might be. But if we don't have a cure, we have to control it and manage it. And that's what pain management's about. So when we see options like IVIG, when we see other options, new and upcoming treatments that can offer some sort of added improvement, the whole idea is to get them, minimize their pain, get them functional, get them to a lifestyle that they can live, not be miserable. You know, that's what we're trying to have them accept, because I wish I could make everyone's pain go away, but it's not always the case.
So a lot of my viewers are people that have not been formally diagnosed.
Right.
And I'm trying to change that and kind of get the messaging out that if they're having these symptoms, it's whatever it might be, whether it's a mild, small fiber, whatever type it might be, or whatever it's stemming from, the sooner they mention it, the better, because the testing will take time and then that will inform treatment. But a lot of people just want to do the supplement route or the home, which is fine for mild, I would think. What do you say about that?
Supplements have a role. Granted, everyone wants to live like a more organic, a more healthy lifestyle, right? So like by doing so, by all means, I encourage it. But too much of a good thing is also not good. Right. Like we have to monitor, because even though it's off the counter and it's over the counter, you feel it's safe.
Not regulated.
It's, not regulated. You don't know how much of it you should be taking, like vitamin C, for instance. You take it, you could take too much and end up with a problem like rickets or something like this. You can have even with B12. Like B12 is fairly safe, because if you take B12 excessively, you'll excrete it out, But some things that people take too much of, and you think you're doing the body good, can actually lead to a
Hallelujah.
backlash.
Because the reason I'm saying that right now is because I also I covered the craze of getting these vitamin infusions with high dose. And, part of me was kind of like, look, if you're eating a balanced diet, which, is debatable nowadays anyway, but if you're eating a balanced diet, you're getting these vitamins in that. And most of the people going for these infusions are pretty healthy.
Infusions, you mean the wellness infusions? Yes. Okay.
Yeah. So my caution here is, where might we be harming and causing a neuropathy with all of these high dose vitamin C, B vitamins, there's the Myers cocktails and all that.
Yeah, like B is one that you can take too much, too little, and then end up with a problem.
Right.
So, yes, use them, but use them cautiously. I wouldn't be at these type of IV clinics and getting it weekly, because it sounds restorative, but it may not be what your body entirely needs. A multivitamin in itself pretty much gives you a drop of each vitamin to give you something baseline, steady state in your system, but it's not correcting any deficiencies. What you need to do is get a full battery of tests. If you're dealing with peripheral neuropathy or neuropathic type symptoms, get a B complex panel done, get your hemoglobin done, get your ANA done, get your rheumatoid thing, or if you're dealing with fatigue, get all the markers that kind of look in to see what iron deficiency, all of these things can give you those type of problems. People don't look at that. Thyroid, these things are sometimes overlooked. And then the sentence I'll hear is, all my labs came back normal. There's 1,000 labs. How do you know what lab was done and they don't have it? And we need to see that data. So the onus becomes sometimes making sure you have all the data. And who's going to give you the data? Either the patient or be vigilant about getting all the data that you need to make sure that we're sending them the right way. Wow. I mean, oftentimes with this sort of diagnosis, I kind of see fatigue part of this. So then there's almost like a chronic fatigue workup that you do, where we look up Lyme's titer, we're looking up thyroid, we're looking up iron, we're looking up folate, we're looking at the B deficient B panel, HIV, anything. Any of these things can be an indicator, a clue. At least it starts a ball rolling if they haven't had it done.
So somebody who is formally diagnosed with an autoimmune neuropathy, I know there's a graduation of treatments. Usually they'll try gabapentin and what do you think about low-dose naltrexone and all of those types of treatments, and then IVIG, obviously?
Right. So in the world of pain management, we see a lot of patients who were or are on opioid treatment, right?
Yeah.
So opioids have been the least favorable for neuropathic type pain, but they feel like that is what works and they need it, and that's going to be.
It makes them not care about the pain.
Yes,
that's
the pain is kind of annihilated at that point with being on these killers, but painkillers. But they come with side effects, as any of the anti-neuropathic agents. They all come with side effects. Now, we see gabapentin used, and technically it's being used off-label, right? So it was claimed as a seizure medication, a very weak seizure medication, and didn't really find efficacy in seizures, but they found that people with pain were doing really good, and then it just started snowballing into a off-label use. And gabapentin has become very much standard of initiation of controlling nerve-ending fibers that are just erratic and firing and not giving them, calming those symptoms down. But with it comes sedation, nausea, vomiting, all, those GI disturbance, weight gain.
Head feel.
All these things come in with any of those anti-neuropathic agents. Cognitive offset, you can see all of that happening. So that would be one introduction of a medication. Then there's cousins of the gabapentin that kind of do very similar things. So that may be something they may be on. Now the thing with these medications is that it could be subtherapeutic. They'll be saying to me, I've been on gabapentin, I've been on Keppra, I've been on Lyrica, but nothing happened. It didn't work. Okay, so you have to give the medication a chance. We cannot escalate the dose too quickly, because by escalating it, you can suffer side effects. And there's my neighbor is on 300 3 times a day, and or I've been on it for this problem, and it's back to the education piece where you got to let the patient know, let's be patient, I'll see you back in a week or 2 weeks, let's titrate the medication, let's bump it forward as quickly as possible, but watching your side effects. If the side effect comes before the resolution of pain, I may have to stop it or switch the drug, so, you know what I mean? Because they may come to me saying, I'm feeling cognitively off, or I'm very sleepy, I am sluggish, and that's at 300 milligrams.
Right.
And if they're on that, I won't be able to escalate because they're not going to tolerate it, so I'll switch the drug.
Okay.
And if by switching the drug and I switch and I see relief, great. I might have to add 2 drugs of similar class to get the relief. If that doesn't work, then we look at options like infusion. We look at infusion as a potential, and many patients are not aware. So infusion is something that has given relief to patients that have not seen relief with any other means, or they're limited by medication, or they have metabolic issues that they can't, have,
steroids.
Yes, they can't have steroids, or they have kidney liver dysfunction, because these anti-neuropathic agents, if they're kidney dysfunction or, they're having problems with the kidney, renal functioning, or liver, then we have to caution them on escalation of that drug.
Really complex. They can be so complex. And then what about low-dose naltrexone? Where does that fall in here?
It's, okay, so naltrexone being used to combat opioid habitual use, or using it, kind of counteracting the effect. But studies have been shown that at very low doses, it can be effective for pain. It's not a full game changer, but it's been effective, and it has, even ketamine is also out there. So, so low dose naltrexone, you can see we're using it in cases like fibromyalgia. You can see effects with fibromyalgia on very low dose, like 4.5 milligrams. But it's something to consider as an option. You know, everybody's different, right? So everybody responds differently to different treatments. That's the tricky part.
So, Dr. Gupta, you sort of have navigated us through your thought process and the different treatment options for these patients, and sort of the hypothetical, boxes that you're checking off as you're going through. You're looking at their symptoms, you're looking at what they've been treated with. You get to the point where you have a patient where you think, okay, this patient would be a candidate for IVIG. Picture yourself in the exam room with this patient. How are you, bringing this to their attention? How are
Right.
you know, offering this treatment option as a therapy, and how are you navigating that conversation?
Well, first, I mean, this is after we've concluded that what they've done in the past. Like, if there is no box like that has been checked off yet, like there's nothing that we can say that, okay, this avenue has not been explored, but I've pretty much seen a thorough treatment approach that they've gone from basic to conservative med management, not responding, and you know, they're having this kind of this losing hope attitude that nothing has worked, and we're unfortunately dealing with an idiopathic sort of situation where medications aren't responding. There's nothing that we can do. Then I present this option to them. I let them know that this may be something that we can talk about if there is candidacy. Right? So we have to prove to see if there is any type of nerve involvement, if in fact it is. We don't know yet, you know. So like if I don't have like an EMG study, but I have lab markers and they failed a bunch of medications, they're not responding, and what we're missing maybe is an EMG and the biopsy, I might even just get both, because that 2 data points can give me information if we can proceed down this route.
One or the other.
Yeah. Right. Or if not both. Yeah.
Exactly.
Or if not both. Labs should be looked at, diagnostic, x-rays, if those things have all been cleared up, and medical history is all in alignment that, okay, it can't be this, it can't be that, everything's been ruled out in my thought process. Then if there's any battery of labs needed, I might order those couple things, but chances are I'm now looking at adding and exposing them to this sort of treatment option, because at this point, mostly, if like I get to this point where I'm having this discussion, they're desperate.
Yeah.
There's a desperation mode, and they're looking for some resolution, because then we're dealing with issues, comorbidities of depression.
Sure.
And that comes like hand in hand with this diagnosis.
Sure. Yeah,
I mean, I don't know if you see that, right?
All the time. All the
Yes.
time.
It's a depression, anxiety, frustration. I
Right.
mean, you know.
I'll always ask and confirm, but right out of the gate, I list all 3 of them, you know, before I even ask them if they have a medical history of it, because if they have neuropathic pain, then I know they probably do.
So it sounds like, you know, casting this massive net of peripheral neuropathy patients, that it's not to say it's for everyone, but it's as you go through the process of weaning down the tried and failed, what their symptoms are, you know, how long they've had it, the progression of the neuropathy, then it's a matter of, okay, this potentially might be a candidate.
Right, because a lot of these cases of some, let's say, like you're looking at the forest versus the trees, right? So the forest you can easily capture with basic treatment of putting an anti-neuropathic, doing some sort of mild pain agent. You can kind of, you know, correct some deficiencies. Those things are kind of rectifiable, right? But then once we've passed that and we still have this pain process, then we have to look at some other options. And you have to also consider, I mean, this is one thing we didn't even touch on, but the time factor. How long have they been suffering with this problem? Because there's this whole phenomenon of neuroplasticity, right? So neuroplasticity is basically like the longer you suffer with pain, the longer it centralizes, it becomes part of the nerve memory. And no matter what you do, you're not going to be able to eradicate that. You can't break that down. I mean, there's functional MRIs that show neuroplasticity with chronic pain patients, that the pain is embedded. So that's why we really try to be a little aggressive in moving forward with medication, identifying things, what worked, what didn't work. And we like them to kind of be in close communication of what they've been doing. If you wait 20 years and you're suffering, it becomes more challenging.
Dr. John Sarno, I think he did it's perceived pain, that the body is automatically, and he did a lot of work with back pain. In that respect, but a lot of people have now carried that over into the neuropathic arena with his work, which is really very interesting. Some people have made entire careers out of piggybacking off of his work and treating pain, but the whole premise of that is that they need to rule out all the mechanic, metabolic, you know, all of those issues, and if the pain still remains, then then it's almost like a, there's a methodical way to move through it, but it's, I think I want to say a little bit of hypnosis and a little bit of, cognitive therapy, behavioral therapy.
100%.
And so, yeah, it's very interesting.
And that's a lot of how pain perception is. Patients perceive pain very differently. Like the threshold of pain for someone is, for you, maybe different than his and mine, and everyone perceives pain very differently. So that is one aspect that you keep in mind, the psychological aspect of the pain, the burning. Some people can function with burning and tingling, but as soon as they start having weakness, and as soon as they start seeing that they can't feel the ground when they're walking on the ground, and that happens, then we run into other potential physical risks of their health, and falling, fracturing, or doing something that could potentially be more risky.
Through, his front living room window because he couldn't feel the brake.
The gauge, the temp, the pressure of the gauge.
A lot of times when I'm talking to some of our patients, we'll talk about the peripheral neuropathy symptoms, like the burning, numbness, pins and needles sensation, but then they start talking about their gait and their mobility and their
100%.
functionality. And now we're crossing over into potential a large fiber movement disorder type situation. So hence why casting the net of the EMG and the skin biopsy, the bigger the net, the better the finding.
Right, exactly. Like having that data there. So the biggest take-home point that I would say is don't ignore the symptoms, get it worked up. If you be your own advocate with your doctor, and getting the information that if they don't have it, then get it done and present it, because you're your only advocate at this point, and learn about the syndrome, by you doing this sort of thing. This is great because it gives them the platform to understand and ask the right questions.
Well, thank you very much for talking about this today. My viewers have so many questions all the time, and I try and cover it as best I can, but it's always wonderful hearing from a true expert in the field in both respects, in IG and pain management. So thank you both.
Oh, thank you. Thank you.
All right.
Stay lucid.
Lucid meds
Stay
out.